Dr. Ambright kindly agreed to do a brief introduction.
It gives me a great pleasure to introduce today's Grand Round speaker, Dr. Chris Morano. Chris went to undergrad at University of VA. If I remember, it was some kind of engineering degree. Is that correct? Okay. Medical school here at the University of Maryland and residency here at the University of Maryland, and a neuropsychiatry fellowship, geriatric fellowship at here, and then for a brief stint across town over at Hopkins, and then came back here. He's now the director of Division of Geriatric Psychiatry. He also runs the adult inpatient service and the ECT service. And actually, he's been a very core member of the education team as well, and has agreed to host Grand Rounds for us. So without further ado, Dr. Chris Morano.
Thank you very much, Dr. Ehrenreich. I appreciate that. So welcome, everyone. I talk a little today about Alzheimer's and kind of a bit of an update. I know that kind of as the Grand Rounds coordinator, I've been kind of sitting on this topic until there was a time when we maybe didn't have a speaker who could make it, and I felt that there was probably enough, enough of to say that you can give a reasonable update, and I think we're there now. I look back and I hadn't really given a talk like this in about 5 years, so I think in those 5 years some important things have happened, and hopefully we'll be on on the way to some better care for our folks with Alzheimer's and other dementias. No, this is not. Andre, my slides are not advancing. Oh, I see the issue. Okay. Nope. Oh, all right. Thanks. All right. So first off, disclosures. I have no relevant financial disclosures. I will mention that there are no FDA-approved treatments for behavioral disturbances in dementia. So we'll talk about that briefly, and I will reference some unlabeled and unapproved use of multiple agents. So what do we want to talk about today? Well, the first thing really do is kind of describe the relationship between the pathology and symptoms of Alzheimer's disease using current biomarkers, because this has been really an evolving process over 100 years. Want to review some of the treatments for Alzheimer's, including some new anti-amyloid therapies. And finally, kind of talk a little bit about the core features of comprehensive dementia care. So I will say my slides are probably more detailed than I have time for in an hour, in keeping with our new 1 hour Grand Rounds. I'm going to try my best to stick to it. I may go over some things. If you have something doesn't make sense on a slide, I'm happy to talk afterwards, or I can send you my slides. So what kind of spurred me to do this, particularly when I was doing a lot of work in a memory center, is the number one question we get is, what is the difference between dementia and Alzheimer's? And if you think about it, it should be a pretty simple question, but it's actually not. So the first thing we have to say is, well, what is dementia, or as the DSM now calls it, major neurocognitive disorder? So is this a sign? Is this a symptom? Is it a syndrome? Is it a disease? Well, it's a syndrome. It's a group of signs and symptoms that occur together and that characterize a particular abnormality, cognitive and functional decline accompanied by behavioral disturbances. Now, the etiology is the cause of this disease or abnormal condition. So what's causing this syndrome? Well, it gets a little trickier there. And I like to think of sort of heart disease as an analogy. So in heart disease, your symptom can be chest pain. Your syndrome might be angina or congestive heart failure if it gets more serious. But we know your underlying pathology would be coronary artery disease. So what about cognitive disorders? Well, memory loss can be your symptom. Your syndrome might be something like mild cognitive impairment, which we'll talk about, progressing on to dementia. But what's the cause? Is it Alzheimer's? So And that's a good question. So is Alzheimer's disease, a syndrome, or is it something else? And it really depends. And I think there is a kind of a group of some of the real heavyweights in Alzheimer's research who kind of said it's multiple meaning separated by a common name. And I just want to take a little time to talk about that. So first off, brief history. We have on the left, Alois Alzheimer, German psychiatrist. We have August D, who is the index patient. So in 1906, Alzheimer wrote on a peculiar disease of the cerebral cortex. And he describes the case of a 51-year-old woman, August D, who had progressive cognitive impairment and psychosis. She was in the asylum there, and she actually presented her earliest symptom was suspiciousness of her husband. So this is, we still see this today. When she died, Alzheimer did an autopsy, and he found two things. He found plaques, which we now know are made of beta amyloid, and he found neurofibrillary tangles, which we now know are made of hyperphosphorylated tau. So in 1910, Kreplin used this term Alzheimer's disease in his Handbook of Psychiatry to describe the syndrome of rapidly progressive young onset dementia with a pathology that was distinct from senile dementia. So at that point in time, most dementias were considered senile dementias. So this just real briefly shows that pathology of Alzheimer's. You have extracellular amyloid plaques, intracellular neurofibrillary tangles, and you have neuronal death, which you can see on the slide, and then also results in essentially progressive atrophy on a macro scale. So Alzheimer's was really felt to be a rare cause of dementia until the 60s and the 70s, when it was recognized as the primary cause of what was then thought of as senile dementia. Today, we think that Alzheimer's accounts for about 60% of cases of dementia, though the thing you have to remember is these estimates vary wildly, really based on what kind of method you use to ascertain. Is this a population study? Is this a clinic? Is this a neuropathology study? So these things really, really vary, but it is clearly the most common cause of dementia. So, we're kind of dealing with early on is what we'd call a clinical pathologic definition of Alzheimer's. So we have a symptom, a syndrome, progressive cognitive and functional impairment. Memory loss is a predominant early symptom. And then we have a pathology, amyloid plaques and neurofibrillary tangles on autopsy. Now, there's a problem here, though. Autopsy, as you know, is not a useful tool in routine clinical care. So Alzheimer's then becomes really clinically a diagnosis of exclusion. And there's a whole bunch of different definitions. I'm not going to really, belabor that too much, but there was this concept of probable Alzheimer's disease, which was equivalent to what the DSM-3 and 4 called dementia of the Alzheimer's type. So what was this DSM-4 syndrome, dementia of the Alzheimer's type? So here we're talking about the clinical progression, multiple cognitive deficits. You must have some memory impairment, and you must have some other deficit, aphasia, apraxia, agnosia, impaired executive function. Like anything in the DSM, there has to be functional impairment to reach that threshold of dementia. These deficits aren't due to delirium. And really, here we have it. Deficits are not due to other CNS or systemic conditions or substance abuse. So really, it's everything else that we can't figure out exactly what it is. Now, this really created some diagnostic challenges. So one thing is that we learned with time is that there are other non-amnestic clinical syndromes that exhibit plaques and tangles. So you have what we call posterior cortical atrophy, which is the visual variant of Alzheimer's, presents early on with visuospatial dysfunction. There's the logopenic variant of primary progressive aphasia, which sort of presents initially with difficulty in producing language. There's this Alzheimer's dysexecutive syndrome, where really profound difficulties in executive function are the earliest syndrome, and even some forms of corticobasal syndrome have Alzheimer's pathology. The other thing that really creates a diagnostic challenge is this idea of mixed pathology. Our brain isn't really as clean as we would like. And I think a study that kind of best exhibits this was the Honolulu Asia Aging study. And what they basically did, they have 443 autopsies of older Japanese American men over between 1991 and 2003. And when they looked at these folks on autopsy, when they passed away, they really find that it was 5 different pathologies that explain most of the cognitive impairment later in life. There's the Alzheimer pathology, plaques and tangles. There's vascular pathology, microinfarcts and lacunar infarcts. There's Lewy bodies. There's hippocampal sclerosis, which is something we're recognizing more and more today. And there's atrophy. And the clinical presence of dementia is actually more closely correlated with the combined number of lesions and the severities than with a specific lesion type. So basically, as you get older, if you have cognitive impairment, or even if you don't, you're most likely to have multiple pathologies. So DSM-5 came out in 2013, and the DSM-5 tried to address some of this. Basically, the change was, well, now they separated major neurocognitive disorder and mild neurocognitive disorder, which we'll talk about, from the actual etiology. So we're going to separate our syndrome from our etiology with the hope that with time we will have biomarkers or better living diagnosis of our disease. So basically, the syndrome basically says you have to have impairment in one or more cognitive domains. Interestingly, no longer has to be memory. And they added a new one, social cognition. And this is to really capture some of these dementia syndromes like frontotemporal lobar degeneration, when behavior changes may be sort of the first symptom. You have to have concern from the individual, informant, or clinician that there's a decline in function. You have to have some sort of cognitive assessment that indicates there's impairment. Again, the functional mark, you have to interfere with the independence and the instrumental activities of daily living, paying bills, managing your meds, driving. It's not a delirium. And again, we still have this disclaimer, better explained by another mental disorder. The other new concept here that with the DSM-5 was this major versus mild neurocognitive disorder. So basically, it's a difference in severity. The criterion for the cognitive decline is modest. There's not sufficient decline to interfere with independence. Well, why it matters? Well, these both may be caused by the same progressive disease process that we want to try to treat. And it also caught us up with sort of some of the terminology that was being used, where you have major neurocognitive disorder being dementia, and then mild neurocognitive disorder kind of equating to this syndrome of mild cognitive impairment, which would kind of come into the literature. And of course, the DSM now gives us a whole bunch of different etiologies that could cause mild or major neurocognitive disorder. Now, what about Alzheimer's? So Alzheimer's, we're still sticking with some clinical description: insidious onset, gradual progression, one or more cognitive domains, does not explain by something else, so our exclusion is still there. But they take a little bit of a step, and this is a step that had previously been taken in some other definitions, but they basically separate between this idea of probable Alzheimer's disease and possible Alzheimer's disease. So this is a way really to separate that our diagnosis from our pathology if we can't see, how confident are we of our pathology? So they're tiptoeing this. They're basically saying it's not a biomarker, but their causative agent is a genetic mutation from family history or genetic mutation. And then they say, you have to have all 3 of the following: clear evidence of a memory decline, steady progressive decline without plateaus, no evidence of a mixed etiology. So we're putting maybe a tiny bit of something that we can measure, your genetics, and kind of incorporating that into a clinical definition. Just as sort of an aside, the question comes up, what happened to dementia? And it's really been subsumed by major neurocognitive disorder, though, and you can use them interchangeably, and I probably slip between them. dementia is retained for continuity. Most non-psychiatrists don't use the term neurocognitive disorder. They use the term dementia and mild cognitive impairment. The concern was that dementia really implied a progressive neurodegenerative disorder affecting older adults, but that neurocognitive disorder is more wide. Maybe it's for conditions that affect younger individuals, traumatic brain injury, HIV, and may not be progressive. Now, a new challenge came up in sort of how we define and diagnose Alzheimer's, and that's biomarkers. So over the last 20 years or so, we have developed many biomarkers for Alzheimer's disease, really biomarkers of amyloid, beta amyloid, and neurofibrillary tangles. And they come in a number of different forms. So though the figure doesn't show this, really the first thing that kind of we saw as a biomarker was in the cerebrospinal fluid. So really measuring the ratio of different types of beta amyloid, measuring the amount of phosphorylated tau. This could give us an idea of this correlates with sort of what's happening structurally in the brain at autopsy. Now, later on, CSF, not everyone wants to go through a lumbar puncture. The next thing that kind of came along was imaging biomarkers, and really kind of the real breakthrough in this was in the late 90s or early 2000s was the Pittsburgh compound. So basically, this was the first compound that could actually visualize beta amyloid in the living brain. And this was a real breakthrough. Wow, we no longer have to have an autopsy or a lumbar puncture to see these things. Now, Pittsburgh compound kind of stayed as a research entity. It's carbon-13. You can't really, not easily used clinically. So there's some new fluorinated ligands, which we'll talk about. So we had first we had PET for amyloid. Later, maybe last 10 years or so, we've had PET that can take a look at tau or neurofibrillary tangles. We have markers, with some of the more sophisticated neuroimaging we have. We also have markers of neurodegeneration, basically atrophy on MRI. We have some other PETs that look at fluorodeoxyglucose brain metabolism. So basically, we have a lot of ways now to see this pathology in the living. And this created another issue. What do we learn? Well, first off, we learned that many, and maybe 30% or more of cognitively normal individuals in their 70s and 80s have brain amyloid. And not all of these people will progress to a clinical neurocognitive disorder. The other thing we found out is that many people with a clinical diagnosis of Alzheimer's dementia actually don't have brain amyloid. We've learned there are a lot of Alzheimer's mimics, like hippocampal sclerosis. Finally, we learned tau, which remember is not specific to Alzheimer's. It can be seen in other disorders, some frontotemporal dementias, chronic traumatic encephalopathy. Tau is much better correlated with symptoms than is beta amyloid. So what did this lead to? Well, this really led to some newer biomarker-based definitions of Alzheimer's. Now, these aren't really in the clinical realm quite yet. They're sort of in the research realm. But what's interesting is, and this just looks at two of them, there's the International Working Group criteria and the NIA Alzheimer's Association criteria. The important thing here is to kind of look at the progression from left to right. So you have someone who has no amyloid and no tau in their brain. We could call them normal, AD biomarkers, cognitively unimpaired, or in the International Working Group criteria, not at risk for progression to AD. Now, what if you have someone who has amyloid but no tau? So, this person, and this is a person without symptoms, mind you. This would be called preclinical Alzheimer's pathological change. So we have one of the two pathologies. We have amyloid. And this would be called someone who's at risk for progression under the other definition. Well, what if you have amyloid plus tau? But what if your tau is only in the medial temporal cortex? Well, that would become called preclinical Alzheimer's. Now, we do have both pathologies, or in the other one, at risk for progression to AD. And then finally, what if you got amyloid and tau in the neocortex, but you're symptomatic? Well, that is preclinical Alzheimer's, still at risk for progression under the other definition, the International Working Group. But the thing is, as you go progressively along this line, you have a higher risk of someone who is not cognitively impaired into developing a neurocognitive disorder. And this was really something very, very new. And this actually, well, the question is, well, we have all these biomarkers. What we really want to know is, do they predict progression? You know, if an asymptomatic person has these Alzheimer's biomarkers, will they progress to cognitive impairment? And actually, this is like hot off the press. This came out like a couple days ago from Nature Medicine. And basically, amyloid and tau PET positive, cognitively unimpaired individuals are at high risk for future cognitive decline. And I thought this was a really, really good study. I hope this projects well. Not sure, but basically what we had is we had a group of people who, more than 1,000, who were followed over up to 6 years, but a median of about 3.5 years. And these were people who, at the beginning of the study, were cognitively normal, and they had various levels of Alzheimer's biomarkers. And what they looked at over time is what happens to these folks. So they separated mild cognitive impairment from dementia. So, but the message is essentially the same. So if you have no amyloid or no tau at the beginning of the study, you were at very low risk of progressing to any kind of cognitive impairment. What if you had just amyloid but not tau? Well, here you are at risk for progressing, but really, really not all that much. But what if you have tau? And this is where things really seem to change. If you have tau at the beginning of the study, you can see the green line is in the medial temporal, the dark line is in neocortical. These people have very, very high risk of progression. So if you look at hazard ratios, if you have just amyloid, your hazard ratio is about 2.4. If you have amyloid and neocortical tau, 14.6 is your hazard ratio for progressing to cognitive impairment in 6 years. If you have it in both, if you have it neocortically, 19.2. So really what we're seeing is these biomarkers do predict progression, and particularly tau. Well, I want to shift gears. We're going to talk some more about biomarkers and how they impact our current clinical care. But for now, we have to say, like, why do we care? You know, what's so important about Alzheimer's and other dementias? What's their public impact? Well, the one thing we know that it's really, really common. Okay. And this is from the Alzheimer's Association, who puts out a very nice document every year called the Alzheimer's Disease Facts and Figures. And this is from 2022. And basically what it says, and they break it down by ages. So the oldest is purple at the top, your 75 to 84 is in the middle, and your 65 to 74 is at the bottom. So we say in 2020, I think there's about 6.1 million people in the United States with Alzheimer's dementia. We have an aging population. By 2060, we think it's going to be 13.8 million. And where's that coming from? It's really coming from the oldest old, because these are the people that are now living longer. So a lot of people. This doesn't just happen in the United States. This is also happening in sort of developing countries around the world. We're expecting to see maybe 35.5 million people worldwide with dementia in 2010, doubling every 20 years, and about 115 million by 2050. It's also really costly. And I just put this up. I mean, this is sort of an advocacy slide from the Alzheimer's Association, but this is very, very costly disorder. The cost in 2022 dollars for all payments out for Alzheimer's or other dementias is estimated $321 billion. Now, 64% of this is covered by, not my Medicare, I don't have Medicare, covered by Medicare and Medicaid. About a quarter of it is out of pocket. And this doesn't include informal caregiving. So we're not saying this doesn't include sort of the loss of income that someone may have from being a caregiver rather than working. Alzheimer's is also the 5th leading cause of death in people over 65 in the United States. Remembering, this is a chronic disease. Life expectancy from diagnosis, maybe 2 to 20 years. With time, this patient is going to decline and they're going to depend more on others. This leads to a lot of caregiver burden. And we see that 90% of these caregivers are women. We're seeing a lot of the sandwich generation, people caring both for their kids and their parents, really has a lot, takes an emotional and a health toll on caregivers. This again, just to say, Alzheimer's, number 1, vascular, probably number 2, mixed is really, really common. Some of our other dementias that are listed, like the DSM talks about frontotemporal, Lewy, Parkinson's, HIV, and PH, and again, in the oldest old, mixed. Well, what is a risk factor for Alzheimer's? Well, the major one, the by and far number 1 risk factor for Alzheimer's is age, followed by genes and then vascular disease. We also have some likely risk factors: head trauma, limited education, depression. The relationship between depression and dementia is very, very complicated and something of a great interest in, but that's really a whole nother talk. Well, the ones we care about are the modifiable risk factors. And what are they? Well, they're the vascular risk factors: smoking, midlife hypertension, midlife high BMI, midlife high cholesterol, diabetes, all those things that are so incredibly common today. What about genes? Well, we have a couple different categories here. We have your sort of deterministic autosomal dominant genes, which is really rare, about 1% of cases, right? You have the gene, you get the disease. This is the amyloid precursor protein, which was sort of initially identified because people with Down syndrome at trisomy 21 almost invariably develop Alzheimer's. And there's the presenilins, presenilin 1 and presenilin 2. Probably 99% of the cases are sort of polygenic inheritance. If you have a specific gene, it increases your risk. There's really one that we think a lot about. It's the apolipoprotein epsilon 4 allele. So apolipoprotein, it's a transport protein. You could have a 2 allele, a 3 allele, or a 4 allele. And what basically happens is, if you have 1 copy of the 4 allele, your risk of developing Alzheimer's increases. If you have 2 copies of the 4 allele, it increases even more, but it doesn't necessarily mean that you're going to develop Alzheimer's, whether you have 1 or 2 copies. It's not. So, and again, we're talking about a long timeline here. When we start to think about preclinical disease, which, as we have biomarkers, maybe we're talking 15 to 30 years. And this is where we really want to prevent things. We have this syndrome of mild cognitive impairment. We know that some variants have a high risk for progression, particularly an amnestic subtype, but different ones have variants. Some may revert to normal or not progress. And finally, the individual develops dementia. So again, this is, short-term memory loss, aphasia, apraxia, agnosia as it progresses, gait disturbance later, requiring total care towards in late course, and death is often due to things like dehydration, sepsis, or aspiration. This is a pretty widely circulated schematic that was done by some of these heavyweights in the field, kind of looking, well, how do these biomarkers that we have correlate with what's going on clinically? So basically, if we're looking on the x-axis, we're talking about disease stage. Do you have symptom? Are you normal? Do you have mild cognitive impairment? Do you have dementia? And then on the y-axis, we're really looking at the magnitude of this biomarker. So what do we see here? Well, what we see is beta amyloid seems to increase first, often while someone is cognitively normal, followed by tau. Remember, we said tau correlates much better to symptoms. But before that, we're going to start to see changes in brain structure. We may see atrophy. Yes, so beta amyloid is the first in the cascade, this proposed cascade, but having beta amyloid alone does not necessarily give you symptoms. Tau, develop symptoms, people more likely have also will have tau. So basically, again, this is hypothetical. This is not proven, but it's fairly widely accepted. You go from amyloid, then you see the biomarker tau, then we start to see changes in brain structure, atrophy, in particular parts of the brain, later global. Then we see problems with memory, and ultimately you have cognitive and functional difficulties, which would, qualify for a clinical diagnosis of dementia. So we talked about biomarkers, where things are going, the definition. I just want to kind of shift gears a bit in the rest of the talk and talk about how we evaluate patients for Alzheimer's and other neurocognitive disorders. So how do these folks present? Well, often it's not the patient, but it's family and friends. Chief complaint can be a lot of different things: forgetfulness, losing things, repeating conversations, loss in familiar areas. A couple that kind of often get mistaken for depression may be like a loss of interest, decline in hygiene. People may be depressed, and sometimes it is depression. That's a risk factor, but sometimes it's more this apathy. People may even present with paranoia, like August D did. We're still at where we are right now, evaluation is pretty straightforward. You want to get history from the patient and the family, make sure you're assessing for cognitive, functional, and neuropsychiatric symptoms. And one thing I found is that you really need to obtain history from the family or friends without the patient present, because this would be the very common scenario. We'd have the family drags their mom or dad into the appointment very begrudgingly, and patient doesn't think there's anything wrong. Family doesn't want to tell you everything that's going on because they got to ride back home in the car with that person, and it can be pretty rough ride. So really important to get some to really have some time to hear from the family. An examination, including a neurological exam, so important to do a physical exam. And then we have some diagnostic tests, which we'll talk about. Pretty much the cognitive assessment, some blood tests and some brain imaging are pretty much always done. Sometimes we do CSF tests, sometimes we do an EEG, and we'll talk about this a little bit. I'm not gonna dwell on this. By and large, bedside cognitive testing is enough to make a diagnosis. And the usefulness really depends on the screen, on the instrument. Remember, these are screens, they are not diagnostic gold standards. And as you guys probably all know, now the most common is the MoCA, which kind of has supplanted the mini-mental, because we know the mini-mental may not be helpful in milder syndromes, high IQ, or for it doesn't really assess executive function at all. There is a subclass of patients where we may refer for tailored neuropsychological testing. Is this younger, someone who's younger, or the deficit's kind of atypical? By and large, we don't have to do this. And it can be expensive and time consuming. This is just the MoCA, which is kind of the test, the number one test we all use. What about labs? Well, here again, we are still looking in this exclusionary sort of paradigm. Are we looking for other things that could cause cognitive impairment? We might get some other bloods, So then we have, things we might think about. Well, for some things unusual, we might get some inflammatory markers, we might get a Lyme, we might get an HIV or an EEG, and may sometimes get a lumbar puncture. And this really has two roles now. Number one, which is probably still the most common role, is to exclude other etiologies, right? Does this person have some kind of, paraneoplastic syndrome, limbic encephalitis? The other thing this can do now is provide biomarker evidence of Alzheimer's, as we talked about earlier. But again, then we move on to neuroimaging. Though we've talked some about neuroimaging is a biomarker, it's still predominantly a rule out in clinical care. In Alzheimer's, structural neuroimaging is not diagnostic. It can give us a lot of hints if you do very sophisticated measures. Atrophy really overlaps with scans of the cognitively normal elderly. We may not see this as much because if we order a scan on someone, they may have a symptom. But if you talk to like the radiologist, it's like, oh, this is nothing. We see this atrophy every day. So again, scans are still mainly done to exclude other abnormalities. Well, what scans do we use? Well, we kind of have two. CT, it's quick, it's readily available, but it is at a much lower resolution. There is some radiation exposure. And then we have MRI, far, far better resolution. No radiation. The big issue is you got to stay still and it takes longer. Metal becomes an issue, and really implanted devices like pacemakers, they're not exclusionary anymore, but they just make it far more difficult to do the MRI. You have to turn the pacemaker off, and it's a process, and you have to think, how badly do we need the MRI? I'll just flip through some sort of things. Here's a brain MRI in the elderly, and we can see a lot of variation that may not correlate with clinical symptoms. We have on the left someone with a nice full brain. On the right, you see pretty much global atrophy. You might have vascular dementia. In this subtype of vascular dementia, we see profound white matter disease. Frontotemporal dementia. Here, you're seeing sort of this preferential atrophy in the frontal and temporal lobes. So if you look at the top of the brain, we see a lot of CSF. If we look at the back, we don't see as much. And then we can have normal pressure hydrocephalus. That was a pretty dramatic normal pressure hydrocephalus. We see this sort of mushed brain and these huge ventricles. So we're really looking to rule out other etiologies. The other thing that we have is functional brain imaging and neurocognitive disorders. There's really two modalities. Well, one is SPECT, which looks at blood flow. And this has pretty much very much been replaced by PET, fluorodeoxyglucose PET, which looks at glucose metabolism. So what we see is this is an FDG PET scan, and one of the clinical uses for this is actually to differentiate Alzheimer's from frontotemporal dementia. So on the left, red is hot, yellow is intermediate, blue is cold in terms of how much metabolism there is. Normal aging, you got a nice hot brain. Alzheimer's, we're seeing if we look we have temporo and parietal hypometabolism, we get yellow and blue. In the back, if you look at PICS, or behavioral variant frontotemporal dementia, as it's now called, we look at the front of the brain, look at the frontal and temporal lobes, all blue, profound hypometabolism. Now, we also have, as kind of mentioned before, is we can visualize this amyloid in the living brain, and it has moved to some degree into the clinical realm. So Pittsburgh compound in the early 2000s, in 2012, the FDA actually approved its first amyloid tracer, florbetapir. And interestingly, the indication, it's an estimate of beta amyloid neuritic plaque density in adult patients with cognitive impairment who are being evaluated for Alzheimer's and other causes of cognitive decline. And that caveat is very important as we talked about, because there's so much people who have amyloid without symptoms, and we don't know really what that means. There are 3 agents total now that have been approved to image amyloid. This is a typical positive and negative scan. We're really looking here in the gray matter, and we have it's darker, which indicates tracer uptake in the gray matter. And this is actually something you can go on the website and you can actually do the training to read these scans yourself. Not that I'm recommending that you should, but it is something that's, kind of out there. Well, clinically, where are we at with this? What are the indications for PET amyloid in clinical care? Well, there's really 3, and this is from kind of the Society of Nuclear Medicine, and this is pretty much held up over time. So persistent or progressive unexplained mild cognitive impairment. You got cognitive symptoms, we don't know what's going on. Or do you have some sort of, you've gotten to the point that you have dementia, but it's very atypical. Or folks who have dementia at a young onset. What are the things that we not good for? Typical presentations, no symptoms, you know, medical, legal, you know, these really aren't reasons for the scan. The questions still remain. What does a positive scan mean? Particularly in the absence of disease modifying treatments. And we're going to talk a little bit about that in a moment. It's also not reimbursed by insurance. So CMS is actually looking at this. They did a study called the IDEA study, where basically they would primary care practitioners and other specialists who participated in this study could order amyloid scans on their patients, and they would be paid for. The endpoint they were really looking at is, did this change their management? And that would be enough to sort of think, well, would we pay for this? Well, it did change management in some situations. Probably the most interesting one is that we found a lot of people, there was a lot of Alzheimer's type syndrome, but without amyloid. So we're really having, these are other kind of, you know, other etiologies. That was, but it wasn't enough that CMS felt they're ready to pay for it. They're actually doing the new IDEA study. One of the limitations of the first study was it was really a pretty homogeneous population. They're now expanding that, and hopefully we'll get a better idea if this is something, you know, that insurance will be covering. We've gone a little farther now. 2020, we can now visualize tau in the living brain. Again, it's basically to look at an estimate of neurofibrillary tangles in adult patients with cognitive impairment who are being evaluated for Alzheimer's. So again, that same caveat, you got to have symptoms. And there's a big limitation here. So, and not to get into detail on how tau tracers, but not all tau is the same. And so this particular tracer binds very well to amyloid tau. It doesn't bind very well to sort of the tau that we might see in chronic traumatic encephalopathies. There's sort of a disclaimer, do not use it in that, you know, if you're concerned for that condition. Well, you know, the thing is, we talk about this, you know, these are not a PET scan. It's expensive. It's not readily available. If you think about going worldwide, are you really going to have people getting PET scans all over the world? No, it's not practical. So the next step, and this is where I think actually things I hope will really take off, is in blood biomarkers. So can we use it in looking at the peripheral blood? Can we get a good enough of an estimate of these of amyloid and tau that correlates with what's going on in the brain? We're getting there. You know, one of the tests has been FDA cleared, called Lumapulse, but I don't see where you can order it. There's another one, Precivity AD, which is still awaiting FDA clearance, but is being marketed. It's expensive, like the Precivity is $1,250, but it's cheaper than PET. Again, its role is not established at all, but I think this is where things will be going very shortly. Routine care, it's still a diagnosis of exclusion. We want to know, is there neurocognitive disorder present? Is it major or mild? And can we determine the etiology of this neurocognitive disorder, and with what degree of confidence? Is this possibly AD? Is it probably AD, or is it something else? And we do that a lot, actually, with looking for clues for a non-Alzheimer's diagnosis. Well, what are those clues? Younger age of onset, less than 65. Alzheimer's, though, still is the most common cause. It's actually equal with frontotemporal lobar degeneration. We also want to look for things like early prominent language or behavioral symptoms. This raises the possibility of frontotemporal lobar degeneration. Early Parkinsonism or gait disturbances. We think about things like Lewy body disease, other Parkinson's plus syndromes, normal pressure hydrocephalus. It really looks a lot like it's a Parkinsonian gait clinically. And if you have gait as an earliest symptom and imaging findings consistent with that, you know, that's definitely a clue. And finally, rapid progression of symptoms. That makes us really think about something like a prion disease, or now things like paraneoplastic syndromes. So I want to wrap up here in the next few minutes talking about comprehensive dementia care, because this is really where we are right now. We're in this idea of balancing cure with care. So we don't have disease modifying therapies. Well, maybe we do. We'll talk about that. These diagnostic tests really don't have widespread clinical application. And we've been developing treatments for years. So really what we need to do is in the near and medium out term is extend the time course of people with MCI and dementia and really take proper care of 100 million plus patients with dementia worldwide. So I want to give credit to some of the folks that developed this. These are particularly some of the folks I work with at Hopkins, Kostas Laketsos and Peter Rabins, that really kind of looked at this comprehensive dementia care model. So the first thing we want to think about is, well, what is the goal of treatment? Well, we talk about longevity, delaying disability, delaying institutionalization, controlling symptoms, ultimately comfort and dignity for this patient. If you boil that down, it's quality of life. And it's a dyad. That's not just quality of life of the patient, it's the quality of life of their caregiver. Because if that caregiver is getting burned out and can't give the best care to their loved one, then all these things are going to get worse. And we think about really 4 pillars, of a comprehensive dementia care. We have to treat the disease, treat the symptom. And remember, we're talking cognitive symptoms and neuropsychiatric symptoms, supporting the patient and supporting the family and the caregiver. So treating the disease, not to get in too much detail, but basically the large majority of treatment development for disease-modifying agents has run on this amyloid hypothesis, where basically changes in metabolism of amyloid beta is sort of the first step that leads to this cascade, ultimately ending with dementia and plaque and tangle pathology. But here's the problem. All this drug development based on the amyloid hypothesis, we've had a lot of failures. And I'm sure everyone's seen, you'll see brand new breakthrough in Alzheimer's, and then you don't hear anything about it. And then 6 months later, it failed in the phase 3 study. And I put this up, this is as sort of just to give a flavor. Really the first things we found was these vaccines to the A-beta 42. And what they found is, well, these people died, they got meningitis, but when they looked at their brains, the amyloid actually was leaving. So this really got to say, well, maybe this is something we should look at. And there's been different ways of, probably most commonly is to use monoclonal antibodies to amyloid, passive kind of immunity. They've looked at compounds that sort of change how amyloid is cleaved to try to, get rid of the pathologic species. Really, to this point, none of them have worked. I think I saw it seems like there's 99 failed different medicines in Alzheimer's trials so far. So something's not right here. So what do we know? Well, we do know now that we can remove amyloid from the brain. Some of the latest trials using these monoclonal antibodies, you can get amyloid out of the brain. The problem is, does this have any clinically meaningful benefit? And this is really where the jury is out. And I think part of it is, maybe maybe this is looked at too simplistically. Again, this is not to be comprehensive, but, we know, looking at sort of a very rough amyloid cascade, when you have symptoms, getting rid of amyloid, we know, does not help. We don't know if getting rid of amyloid when you're first producing these abnormal species is going to help. There's a lot that happens in between that we know is contributing. Inflammation, insulin resistance, lipid peroxidation, vascular disease. So perhaps we're dealing with I think we are dealing with a more heterogeneous disease where different paths for different people in ultimately getting to symptoms. Now, that being said, we talked about the failures of the amyloid hypothesis. Lo and behold, last year, the first FDA-approved disease-modifying agent came out, aducanumab, or Aduhelm. It's a mouthful. This is a human monoclonal antibody to amyloid. It's a monthly infusion. It costs $56,000 per year. And we have no idea how to use it. And part of that is it came from a very, very controversial approval process. So phase 3 studies, that's the one where you're going for an FDA indication, right? It was initially terminated in their futility analysis because they weren't meeting the clinical criteria of clinical benefit. But when they went back and did a post hoc analysis, they used this for accelerated approval. They're saying, well, we know we can reduce amyloid, and that's a surrogate marker. So this is something under this accelerated program, you know, if you have a serious disease, you can sort of qualify for this accelerated approval. Maybe you haven't shown the clinical benefit, but you'll sort of get a provisional approval. And then really over the next 6 years, they have to show that there's evidence of a clinical benefit. Now, this was really controversial because the FDA approved this agent against the advice of their independent advisory board. And some of them resigned. So this is pretty, you know, fairly unprecedented here. One thing I just want to briefly mention with aducanumab and actually all anti-amyloid therapies is this thing called ARIA. Well, what's ARIA? And you'll hear more about this as time. It's amyloid-related imaging abnormalities. What we know is when you think about amyloid in the brain, it's in blood vessels, as so you take that out, you're going to end up with things like edema and microhemorrhages. They're pretty common, probably about 10% of the time we see this. They're usually asymptomatic and go away on their own, but they can be more serious. Headache, confusion, visual changes, seizure, you may need to stop therapy. And interestingly, as part of the package insert for Aducan, you have to do serial MRI monitoring throughout the year. Perhaps a much better target or I think more fruitful target is really preventing the disease before things happen. And this is really vascular risk factors, controlling hypertension, cholesterol, diabetes, exercising, consuming a Mediterranean diet, get those polyunsaturated fats and antioxidants. You know, I put this up just, you know, what are the key components here? Lots of fruit and vegetables, healthy fats like olive oil, little bits of nuts, they have healthy fats as well. Red wine, flavonoids, very little red meat, but fish is kind of your primary protein. We also know there are cognitive protective factors. Education is a protective factor. We think about having better cognitive reserve, exercise. So really staying physically and mentally active is very, very important. Well, you know, the question arises, well, you know, over the last 20 years or so, we've actually been treating cardiovascular disease, vascular risk factors much better. Is this making a difference? Well, interestingly enough, yes, it is. Though we have an aging population and might have more cases of people with dementia because there's more living people, the actual prevalence of dementia has gone down in people 65 or older by about a quarter. So in 2000, 11.6% of folks over 65 had dementia. It was 8.8% in 2012. Well, why is this? Well, probably the best thing we can think of is that one, education level went up, so maybe people have more cognitive reserve. Perhaps more importantly is that we're treating cardiovascular risk better. And so this may be paying off. Now there we're talking about risk factor reduction before you have symptoms or maybe before you're even at risk in midlife. The question still out there is there a role for risk factor reduction in patients who are already at risk or maybe even have symptoms? And this is a little bit up in the air right now. There was a study done, I think 2015 called the FINGER study. I don't remember, it's Finnish. But basically it was a large study, 2 years, and it was an aggressive multi-domain intervention, dietary education, formalized exercise program, cognitive training, vascular risk monitoring versus usual care. And what they found was, it was a large randomized trial that yes, you could improve or maintain cognitive functioning in some at-risk elderly people in the general population. There've been some other similar studies which didn't show a benefit. And right now there's actually a number of FINGER studies going on to try to kind of sort this out. Switching gears a little bit, talk about treating the symptoms. If we're not, we hope to treat the disease. Right now, we're really treating the symptoms. And the FDA approved treatments for Alzheimer's are the cholinesterase inhibitors, and which there are three, and then there's the NMDA receptor antagonist, a class of one, memantine. These are pretty well tolerated medicines in general, but fairly modest benefit. We don't know who's going to respond. Some respond better than others, but if you looked on average, you might be talking like a point or two on a mini mental. We do know that patients with Lewy body seem to respond better to cholinesterase inhibitors than patients with Alzheimer's disease. And even some of the early studies may have been confounded by the presence of people who really had Lewy body in those trials. And ribostigmine is also FDA approved for Parkinson's dementia. And these run on sort of the earlier hypothesis about Alzheimer's, which was the cholinergic hypothesis. You have degeneration of these cholinergic neurons in the basal forebrain. You have decreased cholinergic transmission to the cerebral cortex. And then because we know that acetylcholine has a role in learning and memory, this cholinergic loss contributes to the cognitive deterioration of Alzheimer's. What are the adverse effects? Mostly GI. More serious, you think about more acetylcholine, slower heart rate. So your heart rate slows, you have syncope, and you pass out and you fall. So we do know that they do slightly increase the risk for syncope, pacemaker insertion, and hip fracture. What about the neuropsychiatric symptoms of dementia? Because we want to touch a little bit on treating them. We know that cognitive and functional symptoms are the hallmark, but really neuropsychiatric symptoms are universal. And these are the ones that really seem to be associated with some of the adverse consequences: quality of life, more disability, accelerated decline, caregiver burden, earlier institutionalization, and accelerated mortality. So these are really, really important. It seems like families can often tolerate being asked the same question 100 times a day, but being accused of stealing or infidelity or things like that is not as easily tolerated. So this is, what are the symptoms that we see? Well, this is the neuropsychiatric inventory. This was developed about almost 30 years now by a neurologist, Jeff Cummings. And it's basically just sort of a listing of all the different symptoms we may see in dementia: delusions, hallucinations, agitation, depression, anxiety, not much elation, apathy, huge, disinhibition, a lot of irritability, motor disturbances, pacing, sleep disturbances, eating disturbances. We think about things, sundowning. Someone asked, man asked to go home every day and in the afternoon when he's there with his wife. Resistance to care, combative with ADL care, paranoia, someone barricading themselves in their room, slayability, we have a man who may refuse to eat or stop watching TV, and if you get very upset if you ask to do otherwise. Agnosia, and this is pretty common. You don't recognize yourself in a mirror, and you look in a mirror and you think there's a stranger there. One intervention has to cover the mirrors, and then we have these sleep disturbances. And I said I'd finish at 1. I got about 5 more minutes, so thank you for the warning, Andre. I only put this up to say these are universal. Population study in Cache County, Utah. Over 5 years, pretty much everyone had some neuropsychiatric syndrome. Well, how do we treat them? Number one is prevention with good supportive care and sophisticated caregiving. On our end, we really have to accurately identify the problem. So you did a lot of detective work, you got to be Columbo, and you want to rule out delirium. We first try non-pharmacologic treatments: de-escalation, distraction, structured activity. Medicines, we still want to limit them as much as possible. There are no, as I mentioned, FDA-approved treatments for the neuropsychiatric symptoms of dementia. We know that though antipsychotics play a role, they have a black box warning for an increased risk of death. There's some emerging data that antidepressants, they're not actually great for depression in dementia, but they are good for at least milder forms of agitation. Again, we really got to look out for delirium, infections, dehydration, pain. Someone who can't communicate, pain presents as agitation. We've had a run of this on the unit: constipation and urinary retention. really, really important. Adverse medication effects, a stroke. And one thing you have to do, as I say, and I put this in for, for a psychiatric audience, you must perform a physical exam on people and you must walk them. You learn so much by trying to walk someone. And I can't tell you the number of fractures that have been missed over the year and some over the years, and they've come to our unit and they can't walk and it's a hip fracture. So really, really, really important. Last couple slides. And I feel bad that there's only a couple slides because this is really where the most benefit we can have right now is it's supportive care for the patient. Certainly there's emotional support, safety, addressing things like driving. We think that's something that really affects the safety of self and others, living alone, meds, falls. Is there enough structure and a predictable place to live? Don't want to be overstimulated, don't want to be understimulated. Kind of planning ahead for decision-making, managing comorbidities. And in the advanced stages, people often need nursing care. Oops, I put that, I'm in the wrong direction, sorry. What about the caregiver? Of course, we also want to offer support and comfort. Education is huge here. Education on what this is, it's not volitional behavior, this is part of a neuropsychiatric syndrome. Instruction, kind of caregiving, because good caregiving, you can avoid a lot of the neuropsychiatric symptoms. What do you do in a crisis? Problem solve, have a crisis plan. What if you need respite? You just need some some time away to attend to your wants and needs. I'll just end this. This is just if anybody wants some mental health resources for seniors and their families. The Alzheimer's Association is wonderful. They got a great website, information, resources, support group. Despite the name, much of their information applies to all dementias. The National Library of Medicine, Medline Plus, has some great information. There's the Alzheimer's disease, a DEAR Center, part of the NIA, which has great information. There's an elder care locator. So with that, I thank you very much. I think I went about 5 minutes over, but certainly happy in the time, in whatever time we want to use left to answer any questions. All right, anybody? Okay. Oh, yes, Dr. Reeves. You have to push the button.
Can you hear me? Okay.
Yeah, we can hear you.
Chris, that was
Everyone in TV land can hear you now.
outstanding talk.
Oh, thank you.
For us non-geriatric experts. So thank you very much for that. I was curious your thoughts about COVID and if that might give us some insights about these kind of early cognitive declines or potential target population.
Yeah, that's actually very, very interesting. And I kind of debated when I was putting this together, is like, do I want to get into COVID or not? Because it's very interesting that when you look at the data, there's actually a decrease in Alzheimer's deaths in 2020. Well, why was that? Well, because there was more deaths from COVID. But really more importantly, what does it mean? So there is, again, I haven't done the deep dive into the literature, but yes, there does seem to be this idea of, and we've seen this a number of times clinically, someone is getting along, right? They get COVID, they lose their cognitive reserve, and now symptoms become apparent. In COVID, this is probably an inflammatory process. We see it in a lot of other things, particularly like anesthesia for surgery. So I think this is really, really a population, kind of looking at this will give us some ideas of how people may convert. The other thing you can look at in COVID is we know that isolation is sort of a risk factor for conversion. And here we have, millions of people who are kind of, maybe they're in a nursing facility or assisted living, who are essentially prisoners for a year. So I think there's certainly a lot to learn.
You may have mentioned part of this and I just missed it, but I'm wondering about, with much more understanding about the progression of the disease and not necessarily treatments yet. I'm wondering about people getting genetic testing for some of those things, and then also how that sort of plays into thoughts about like death with dignity or euthanasia for people who may have cared for their own parents when they had Alzheimer and now are.
Yeah, no, that's a great question. And something I kind of thought about where do we go with it? And there's really, so what we know is the one thing that's pretty readily available is this apolipoprotein, genotyping. And though you could get it, I think in clinical care, I've really not encouraged anyone to do that because you're going to get information you don't know what to do with. And all that may cause is anxiety. Now, this is totally different from a research perspective because in that realm, we may have differential responses to treatment based on your apolipoprotein status. However, this kind of got really put into the public spectrum really quickly with this 23andMe, who's offering this apolipoprotein, testing, and then they're going to give it to, and what do you do with it? And I think it's hard. You talked about when people like they see their future, right? And sometimes you wonder, do you want to know or do you not want to know? And I think one of the things, and this is anecdotal, that I really noticed probably some of the people who I think were most troubled by what was going on with them were someone who might have mild cognitive impairment, but they had a relative, a mom or a dad who died from dementia and had awful behavioral symptoms. And they say, oh my gosh, what's the point of living here? So I think we've got to be really, really careful with it because we talk about comfort and dignity. How much of this without these treatments? Yeah. What's the benefit? Are we just creating anxiety? So that's a great question, Jane. Thank you. Anybody else? All right. How about anyone out there in TV land? Oh, I'm sorry, Dr. Latour. Or you need to use it so they won't be able to hear you out in the ether.
A little bit about the drug that was targeted for the amyloid. What about tau? Because the data that you showed us doesn't really seem to matter.
Very good. I didn't get into tau. So tau has actually been looked at and tau agents. I don't know if there's anything coming up right now, but there's been some failures already. One that was a study of methylene blue was actually done in FTD and it didn't seem to do anything. So we're not there yet with tau. But yeah, that's a really good question. Everything's been on amyloid. And I think that may end up being one of the real, we don't know. Is that going to be one of the real failures of the field is that we did so much looking at amyloid and ignored all these other things that maybe amyloid and tau are just biomarkers and they're not involved. We really can't definitively answer that, but no, great question.
This is Sheshu.
Yes, Seishu, I knew you'd have a question.
It is not a question, just a quick, because I'm on vacation and watching too much TV. I happened to see on Netflix, Alice Standing, very good about apoprotein E familial Alzheimer's type of disease subgroup, very small group. So people want to know about it. It is a wonderful movie. It is on Netflix.
What's it called again?
Alice, A-L-I-C-E, Alice Standing.
Alice Standing. Okay. All right. Good. No, thank you. That's because there's also a book, Still Alice. That's a really good point. Dr. Doty, these autosomal dominant sort of communities, there's not a lot of people really could be a way that we can really learn about really how challenging these things are from, just deals, but also in treating them because you really have these concentrated populations. There's a couple of studies going on. There's a big family in Colombia with a lot of autosomal dominant Alzheimer's. There's also this Diane study up at Harvard. So yeah, no, thank you very much. Alice Still. Okay. Is that what he said? Alice Walking. Alice Standing. Alice Standing. All right. I'm sorry. Okay. Thank you, Dr. Doty, very much. I apologize for my memory lapse here. All right. Well, anyone else? No? Okay. Well,
I'll ask, how much of what we talked about here applies to the subset of people who are this like early onset Alzheimer's? Is that just a whole other body of literature?
That's actually another really, and I don't think I did not get into, even outside of the autosomal dominant. So the autosomal dominant, that tends to be familial early onset Alzheimer's. That to some degree is a different animal. The one thing we do see is that people with early onset disease tend to have much more rapid progression. Now, and this is not, and I don't know if Dr. Lorick has an idea on this or anyone else. I kind of think of that as that these are people who really lack mixed pathology and will probably have a bigger dose of whatever Alzheimer's is, and therefore they move much quicker. You can actually see if you get past 85, your temperature actually goes down, because you're having this is the vibrant kind of folks, or you'll tend to get in these sort of these people who might. And I don't know, we tend to see it more in women. Maybe they just live longer, but they kind of have this executive dysfunction and psychosis, but the memory's pretty good. And then, yeah, there's definitely something different about it. I don't think we've sorted it all out, but yes, they do progress more rapidly. All right.
Question about the biomarker panel that you mentioned, the blood-based panel. Are those markers early detection markers, or what kind of markers are they?
We don't know, right? So the caveat now is, and the ones that are, well, clinically available, they are clinically available, but they're really not. The caveat is we don't know what they mean in asymptomatic people. And part of that is the current blood biomarkers that are kind of out there are looking at amyloid. They're looking at what's your amyloid and what's your APO genotype. We don't have ones commercially out there that are looking at tau yet, and those might be a little bit more, maybe help us a little more. So now we do not. They almost say do not test people with no symptoms. Don't do the blood. Don't do amyloid because a PET scan because you don't know what you're getting. Push the button. Thank you, Dr. Lorick.
So Chris, actually, we're saying this is kind of along the lines of striking while the iron's hot. What Dr. Moreno was talking, we are evaluating the behavioral complications. And I'm actually asking David, Dr. Latour, hopefully to back me up, how critical it is, and I hope I'm not going to get booed for this, to actually do a neurologic exam on delirium patients. And I could just tell you I've been the chief over the VA. I get a lot of pushback. Oh, they're in bed. I'm worried about they might fall. I don't want to do it. Well, no one ever said to me, I don't want to do it. They just say he's got lines, he's got an IV, he's going to fall. Just went on an incredible practical level to just really strongly hit up. And we're evaluating people for agitation and dementia and delirium. That a neuro exam, it really is critical. And I'm not seeing it done nearly as much as it should.
Yeah, no, and I will say, and of course, anecdotal evidence is always the best. I would say, even in our older patients with chronic mental illness, we should do this. I think of one example where we had a woman, chronic schizophrenia, probably her whole life. We get that she's found down and, by her family, and she gets admitted to an outside hospital. She's really agitated and eventually don't really find anything, and she ends up with us. And the interesting thing is we noticed that the first day she would not get up at all. And then so, and she came to us with a report that she shuffles, is what we heard from the outside hospital. Well, we called the family, we finally get a hold of the family, and they're like, no, she walked beautiful before she came here, nothing at all. Lo and behold, that's one of those times, well, maybe we should get a scan. Huge bleed, right? I mean, that's the worst case scenario, but yeah, it is so important to get people up, walk them, do a neurological exam. You'll thank God you did it. Like if they're your inpatient and then something goes wrong, you say, that was there 2 weeks ago. It's not, this isn't new. You really before it. So yes, excellent idea. All right. Well, thank you very, very much, everyone. I appreciate it. And we'll see you in 2 weeks where we hear some about trauma disorders with Dr. Israel. Yes, sir.
Slides. Longevity. Yeah. Longer longevity. Situations that are